I am Dr. Benjamin Levy. I'm a thoracic medical oncologist at Johns Hopkins School of Medicine, and maybe we can just go around the room and introduce one another.
My name is Dr. Wally Kern. I'm a radiation oncologist. I'm the Chief Medical Officer for Genesis Care, and I'm also Professor Emeritus at Emory University.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Radiology and Vice Chair for Education at Memorial Sloan Kettering Cancer Center. And I'm also a Professor of Radiology at Weill Cornell Medical College.
Mike Lanuti, I'm a thoracic surgeon at Massachusetts General Hospital in Boston. I'm the Director of Thoracic Oncology for our Division of Thoracic Surgery. Also have an adjunct associate professor at Harvard Medical School.
I'm Ramaswamy Govindan, a medical oncologist with interest in lung cancer. I'm a professor of medicine at Washington University in St. Louis.
75-year-old male reformed smoker with new diagnosis of extensive stage small cell lung cancer who has SVC syndrome with dyspnea on minimal exertion, not requiring oxygen at rest, and but does have some of the clinical sequelae of SVC syndrome with bilateral upper extremity and facial swelling. And is worsening symptoms and starting cycle 1 of platinum-etoposide, does have asymptomatic brain metastases as well. And so questions about timing of typical response to chemotherapy for small cell and the role for radiation. So patient presents with cough, occasional streaks of blood, severe shortness of breath with minimal exertion, fatigue and nausea since starting the cycle of chemotherapy. His physical exam is consistent with bilateral upper extremity swelling, right arm more than left, as well as facial and neck swelling, as compared to a photograph from 1 month prior. His performance status is ECOG 1 prior to his SVC syndrome. He's got a history, of course, of small cell and appendectomy as a teenager. Social history, 60 pack year history smoker. He quit 3 years ago. Family history consistent with a brother with prostate cancer and a paternal grandfather with prostate cancer. So we'll go through the imaging here. We've got a CT and a brain MRI. Dr. Ginsberg.
So on the far left, we see the axial images, which demonstrate this very large right upper lobe mass, which measures about 11 centimeters. And distal to the mass, there may even be some atelectasis, but the mass is extensive and inseparable from the mediastinal lymphadenopathy in the paratracheal region, which is also causing the SVC occlusion. We see along the chest wall numerous collateral vessels which go along with the SVC syndrome. And the middle coronal images demonstrate essentially the same thing, a large right upper lobe mass, and on the right hand, same thing, axial higher adenopathy seen in the upper right paratracheal region. So extensive adenopathy, right upper lobe mass, all contiguous and occluding the SVC. And the next images are from an MRI of the brain, which shows multiple small enhancing metastases throughout the brain.
Great. Thanks, Dr. Ginsberg. CT abdomen pelvis lights, as you mentioned, no evidence of metastatic disease. Patient has a bronchoscopy, EBUS, consistent with small cell lung cancer, synaptophysin positive, chromogranin positive, and gets, we can talk about the management decision here, but gets platinum-etoposide 1 week ago. And the question really is, you know, what is the timeline for typical response to chemotherapy? And we can talk to Dr. Govindan about what he would use and whether he would add immunotherapy in this patient. And what is the role for urgent or early radiation if there is no response? So Dr. Govindan, just commenting on the chemotherapy choice here, what you generally do and what you typically expect to see when you institute chemotherapy in a patient like this.
In extensive stage disease, there was a nice phase 3 study done from the Greek group that showed that cisplatin-etoposide is equivalent to carboplatin-etoposide or the other way around. And so I use carboplatin-etoposide in this population. Typically, you see responses in 3 to 4 weeks. Nowadays, we add atezolizumab to these patients or durvalumab. I think that combination is certainly reasonable for these patients, modestly increases the overall survival. I think that will be completely appropriate. And typically, I see responses around 4 to 5 weeks.
Dr. Kern, the role, if this patient doesn't respond, 2 questions here. The role of radiating the chest and when you would decide to do that, what would be the patient triggers or the radiographic triggers to do that after one cycle of chemotherapy or 2 cycles? And then is there a role for radiating these asymptomatic brain metastases? And would you do that concurrently with the chemotherapy if they're small?
Yeah, so as it relates to radiating the chest, I would have a low threshold to come in to basically radiate very early on if the patient is suffering significantly from SVC symptoms. It does not have to be a complete course. Sometimes, 2 fractions of 3 gray each given in an emergent setting can really keep someone out of stress. Now, I'm less worried about, dilated, jugular vessels. You can have, significant pressure on your trachea and mainstem bronchus and compression of other mediastinal structures. And if you can get relief with a couple of fractions, I don't think it's going to compromise. So I would not hesitate to do it. I wouldn't even wait a cycle. If the patient's in distress and Govindan tells me it's going to be 3 weeks before a response, I'd say, let's treat him. You always end up treating the patient at 5 o'clock on Friday, so that's fine. And as far as is there a defined role of thoracic radiation for extensive stage patients following completion of chemotherapy, I don't think the data is strong in that. There's mixed data on that. As far as treating asymptomatic brain mets, you can watch the patient for a cycle or 2, but I'd have a low threshold to give them radiosurgery just to keep them from becoming symptomatic.
Okay, so it sounds like patients should get chemotherapy, potentially with immunotherapy, a low threshold for both radiating the SRS to the brain and also to the chest in the setting of these symptoms. Dr. Govindan, just as we close out here, clearly small cell and an unforgivable disease, it's giving chemotherapy, eliciting these responses. If the patient does have a response, we know that disease progression for extensive stage is generally universal. Your options or your thoughts or therapeutic decision-making post-chemo IO, what do you generally go to in these patients when they develop and if they develop disease progression on first-line treatment, whether it be chemotherapy or with radiation?
Yeah, so I'll speak in 2 parts very quickly. One is in practice and what's emerging, where I see there's a lot of hope here. And, in practice, in terms of chemotherapy, agents that I've seen activity and I've used them are irinotecan based regimen alone or in combination with platinum. We have seen responses. Topotecan has been approved for use, but it causes a lot of myelosuppression. I generally stay away from that. And there are also some novel agents that have been approved. Nivolumab was approved, but then turned out to be not, it did not show superiority over topotecan in the clinical trial, and the approval has been rescinded. Anecdotally, we have seen nice responses to a combination of nivolumab and ipilimumab in this setting. If there is a way you could get that combination, I would use that. So my favorite 2 regimens are, if possible, to get nivo-ip off protocol and available, I would use that. And in the absence of that, I would consider irinotecan-based regimen in these patients. And so I think that's those are the things. And other agents are being considered now and approved. One thing I would point out that is the immune therapy, or in terms of clinical trials, there are bispecific target engagement, BiTE antibodies that are being tested. And in fact, there was a presentation recently at the international conference using AMG 757 BiTE. We and Dr. Karan's colleague, Dr. Obenakako, had presented this data, and that shows some early promising results. And I think these are very promising as we move along. I do think these kinds of active therapies would be of great interest in the active immunotherapy agents are of great interest in the coming years and that are promising in clinical trials.
Great. So I think that's all. I appreciate everyone's input, insight, expertise into these cases.